Chapter 57, Introduction to the Urinary System. Today we're going to name the parts of the urinary system. We're going to define the primary functions of the kidney and other structures in the urinary system. We're going to list tests performed for the diagnosis of urologic and renal system diseases. We're going to identify laboratory tests performed to diagnose urologic and renal system diseases, and discuss nursing management for a client undergoing diagnostic evaluation of the urinary tract. As you can see, the upper tract consists of the kidney, the renal pelvis, and the ureters. The lower tract of the urinary system is the bladder, the ureters, and the pelvic floor muscle. Kidneys, renal pelvis, and ureters. The two kidneys are paired, bean-shaped organs located in the upper abdomen on either side of the vertebral column. They span from the level of the 12th thoracic vertebrae to the 3rd lumbar vertebrae. A thin, fibrous capsule encloses each kidney. The peritoneum separates the kidney from the abdominal cavity anteriorly. There's also a layer of fatty connective tissue that anchors the kidneys in place on the muscle at the back of the abdomen, along with fascia and attached blood vessels. A cross-section of the kidney helps to illustrate the inner structures. The two main areas are the renal pelvis and the parenchyma. The parenchyma is made up of a cortex, outer layer, and a medulla, inner core. Within each cortex are microscopic nephrons that carry out the functions of the kidneys. Functions of the kidney: produce urine, filter and eliminate water and waste products in urine, maintain water balance, regulate pH of body fluids by reabsorbing, eliminating, or conserving electrolytes such as sodium, potassium, hydrogen, chloride, and bicarb ions. Produce hormones that control blood pressure such as renin, balance calcium and phosphorus levels, calcitrol, and regulate red blood cell production, erythropoietin. They also secrete prostaglandins, synthesize vitamin D to an active form, and activate the growth hormone. First, let's talk about the cortex or outer layer of the kidney. This outer layer, the cortex, includes the nephrons. They're microscopic. There are approximately 1 million of them. They're the smallest functioning renal structure. Inside of the nephrons, you have glomerulus, you have an afferent arteriole and an efferent arteriole, Bowman's capsule, proximal convoluted tubules, the loop of Henle, and the distal convoluted tube, and the collecting tubule. These are all inside the cortex, the outer layer of the kidney. In the medulla, which is the inner layer of the kidney, the structures are the calyces, which are pyramids, the renal pelvis, and the ureter. The blood supply comes from the renal artery and the renal veins to the kidney. I should say inside the inner layer is where that comes in, the blood supply. Is the following true or false? The urethra. Question number 1. Is the following true or false? The urethra are the hollow tubes that extend from the kidneys to the bladder. You should have answered false. The ureters are the hollow tubes that extend from the kidneys to the bladder, which drain urine, not the urethra. So again, it's the ureters. In males, they measure approximately 24 centimeters, which is approximately 12 inches. In females, approximately 4 centimeters, which is approximately 2 inches. Is the following true or false? The nephron is the smallest functioning renal structure. This is true. The nephron is the smallest functioning renal structure. While being microscopic in size, there are approximately 1 million nephrons per kidney. Bladder, urethra, and pelvic floor. The bladder, urethra, and pelvic floor muscles form the urethrovesical unit. The urinary bladder, located just behind the pubis, is a hollow, muscular organ. Its shape and size vary with the amount of urine it contains, as well as the person's age. In general, the adult bladders hold 300 to 500 milliliters of urine. The urethra is a hollow tube that begins at the bladder neck and extends to the external meatus. It serves as a conduit during urination and has a sphincter mechanism to prevent urine leakage. The male urethra extends approximately 24 centimeters or 10 inches from the bladder neck through the prostate and the penile shaft to the glans penis. The female urethra extends about 4 centimeters, 1.5 to 2 inches from the bladder neck to the external meatus anterior to the vagina. The pelvic floor muscles constitute the final part of the urethrovesical unit. These muscles form a sling that supports the bladder and urethra, rectum, and some reproductive organs. Urine is formed in 3 steps. The first is glomerular filtration, the second is tubular reabsorption, and the third is tubular secretion. So the main functional unit of the kidneys is the nephron, which we talked about. Blood enters the kidney through the renal artery. After it enters the kidney, the renal artery branches into progressively smaller arteries, arterioles, and finally to a cluster of capillaries known as the glomerulus. The glomerulus is a semi-permeable membrane that serves to filter blood into a C-shaped structure of the renal tubule known as Bowman's capsule. This process, glomerular filtration, represents the beginning of urine formation. The filtrate, which is the stuff that it's coming through, contains water, electrolytes, and water that has been removed from the blood. So this stuff has already been removed, and as the filtrate passes through a sequence of renal tubules from the Bowman's capsule to the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, a network of capillaries surrounding the renal tubules reabsorbs most of the water, electrolytes, and other necessary elements back into the blood. This is referred to as tubular reabsorption. So you're going to keep a potassium and hydrogen ions depending on what's going on with the body. The urine here, pH of the urine here is 4.6 to 8. Tubular reabsorption is affected by antidiuretic hormone. The distal and collecting tubules increase reabsorption if that ADH is released. So they increase reabsorption, and also tubular reabsorption takes place with glycosuria, which is sugar in the urine. Elimination is through the bladder, through the renal pelvis, first through the ureter into the bladder. This is done by peristaltic action. The nerve reflex is triggered. And let me explain that a little further. Excretion of urine, it's formed in the renal tubules, moves into the collecting duct, and then into the renal pelvis, the ureter, and the bladder, where it is stored until urination occurs. The bladder holds approximately 300 to 500 milliliters before the pressure increases enough for stretch receptors in the bladder to signal the need for urination. An internal sphincter composed of smooth muscle contracts involuntarily to prevent urine from leaking out of the bladder. The external sphincter, located just below the internal sphincter and surrounding the upper part of the urethra, is composed of skeletal muscle and is voluntarily controlled. So the external is voluntary. Thus, the process of urination involves a series of nerve signals between the bladder and spinal cord to trigger the Micturition reflex, which is urination. This causes the internal sphincter muscles to relax and the bladder wall contraction, and with this voluntary relaxation of the external urinary sphincter, urine passes out of the body through the urethra. The external urinary sphincter must be under the individual's control in order for urinary control or continence to be successful. As you can see from this slide, that the peristaltic action goes in one direction. The reflex is only happens secondary to distended urinary bladder or infections. Reflex meaning going backwards. Nerve reflex is triggered as far as having to go to the bathroom at about 150 mils of urine. And again, when you urinate, your bladder muscle contracts and the sphincter muscles relax. Urine formation is increased during the night. In the elderly, they drink more during the day, and they should drink more during the day and limit after dinner drinking so that they don't have to get up in the night to go. So getting up in the night is more frequent with aging to urinate. Also, there's a decreased blood flow to the kidneys, so that causes decreased glomerular filtration. There's altered drug excretion because of thickening of the tubules, so they don't excrete the drug parts that need to be excreted. There is a risk for toxicity because of this. There's a decreased concentration of urine, so there's a risk for dehydration, a deficit in thirst, so therefore there's a risk for dehydration again, and a decreased bladder contractility. And the bladder outlet could be obstructed, causing incontinence. Double voiding is when you urinate and then have to go again a little bit later. So when talking about double voiding, is usually due to urinary retention and incomplete bladder emptying, which can result from urethral obstruction, such as men with benign prostatic hyperplasia, shy bladder syndrome, or detrusor areflexia, which is a contractility of the bladder due to an abnormality of the nervous control. Also, you can try, as far as with double voiding, you could try tapping on the bladder area. And what you're doing is you're sitting on the toilet and eliminating urine, and then if you tap a few times on the bladder area, you could probably go again to empty the bladder. So double voiding is trying to empty the bladder to prevent incontinence, and voiding every 1 to 2 hours is also in your plan to prevent incontinence as well. For your assessment, you need to take a personal history, family history, allergies, sexual history, reproductive history, any exposure to chemicals or gas, what the chief complaint is regarding the urine elimination. There is a chance of drug-induced nephrotoxicity, which is 66% in adults older than 60 years old. There's also renal insufficiency, dehydration, diabetes mellitus, heart failure, and sepsis that all affect elimination of the urine. Risk factors include childhood diseases such as strep throat, impetigo, nephrotic syndrome, and eventually or possibly you could get chronic renal failure. Advanced age causes incomplete emptying of the bladder, leading to urinary tract infections. Instrumentation of urinary tract cystoscopy or cath could affect the body by a urinary tract infection or incontinence. Immobilization can cause kidney stone formation. Occupational problems, environmental exposure to chemicals such as plastics, pitch, tar, and rubber could cause acute renal failure. Diabetes mellitus can cause chronic renal failure and neurogenic bladder problems. Hypertension can cause renal insufficiency. Remember, hypertension, you're not getting enough blood to these organs, could cause chronic renal failure. Systemic lupus can cause nephritis and chronic renal failure. Gout, hyperparathyroidism, and Crohn's can cause kidney stone formation. Don't forget about your calcium and phosphorus interaction. Sickle cell anemia and multiple myeloma can cause chronic renal failure. Prostatic hypertrophy can cause obstruction to urine flow, leading to frequency, oliguria, and anuria. Radiation therapy to the pelvis can cause cystitis, fibrosis of ureter, and or fistulas in the urinary tract. Recent pelvic surgery can cause inadvertent trauma to ureters or bladder. Obstetric injury or tumors can cause incontinence, and spinal cord injury can cause neurogenic bladder, urinary tract infections, and incontinence. Frequency can be caused by infection, obstruction of lower urinary tract, etc. I'm going to let you read through this. There's frequency, urgency, dysuria, hesitancy, nocturia, incontinence, enuresis, which is bedwetting, polyuria, oliguria, anuria, hematuria, and proteinuria. I will let you look through this slide for the information. It's a good slide for you. Your assessment is going to include a physical exam, look for scar symmetry and pulsations. As you can see, you're looking at the person from the posterior view. You're looking at where the kidneys would be. If you look at the lower, just below your 12th rib, and you can see the costovertebral angle here. That's where your kidneys would be under that, directly under that. For physical exam, again, inspection, auscultation, you're listening for a bruit, percussion over the bladder. And where you're going to listen for a bruit is just above and lateral to the umbilicus on both sides. A bruit may indicate renal artery stenosis to possible causes of hypertension or renal failure. You would percuss over the bladder. As far as posterior, you're going to percuss or palpate for costovertebral angle tenderness, CVA, of the kidney. You're also going to check the face for periorbital edema, any extremity edema, any cardiac failure history, and also do your heart assessment and any mental changes. Diagnostic tests. In the male client, diseases and disorders of the reproductive system also affect the urinary system. In addition to the diagnostic tests discussed in the following sections, tests that may be performed on the male client and discussed in chapters 55 and 56. Radiography. An X-ray study of the abdomen includes X-rays of the kidneys, ureters, and bladder, called a KUB. It is performed to show the size and position of the kidneys, ureters, and bony pelvis, as well as any radiopaque urinary calculi, stones, abnormal gas patterns indicative of renal mass, and anatomic defects of the bony spinal column, indicative of neuropathic bladder dysfunction. An X-ray of the pelvis, chest, or other area may reveal metastatic bone lesions that could be a result of renal or bladder tumors. Ultrasonography. Renal ultrasonography identifies the kidney's shape, size, location, collecting systems, and adjacent tissues. Other uses include identification of renal cysts or obstruction sites, assistance in needle placement for renal biopsy or nephrostomy tube placement, and drainage of a renal abscess. There are no contraindications to this procedure. It is not invasive, does not require the injection of the radiopaque dye, and does not require fasting or bowel preparation for a renal or bladder sonography. Bladder ultrasonography is another non-invasive test to determine urine volume in the bladder. Portable battery-operated systems are now used by nurses at the bedside for clients who may be in a bladder training program, or if the nurse has determined the need for the client to be catheterized. The head of the scanner is placed on the client's abdomen toward the bladder. The urine volume is displayed on the scanner's screen. Computed tomography scan and magnetic resonance imaging. A computed tomography CT scan or MRI of the abdomen and pelvis may be obtained to diagnose renal pathology, determine kidney size, and evaluate tissue densities with or without contrast material. An iodine-based contrast medium may be injected intravenously after the initial scan to enhance the images, especially when vascular tumors are suspected. The CT scan also is useful in identifying calculi, congenital abnormalities, obstruction, infections, and polycystic disease. An MRI produces sharp images of the kidneys and can delineate the renal cortex from the medulla. It's also useful in identifying bladder tumors, staging renal cell carcinoma, and imaging the vascular system. Clients scheduled for an MRI must not have alcohol or caffeine for 2 hours before the procedure and cannot have food an hour prior to the MRI. Medications may be taken except for iron supplements, which may produce artifacts and interfere with the imaging. Angiography. Angiography of the renal system, renal arteriography, provides details of the arterial supply to the kidneys, specifically the location and number of renal arteries. The multiple vessels to the kidney are not unusual, and the patency of each renal artery. Other reasons for performing renal arteriography are to evaluate renal blood flow following trauma to the kidney, differentiate cysts from tumors, and assess hypertension. A catheter is passed up the femoral artery into the aorta to the level of the renal vessels. Contrast medium is then injected into the catheter and serial x-rays are taken. The radiopaque dye first outlines the aorta and the area of the renal artery and then enters the renal artery and the kidney. A series of x-rays are taken. The catheter tip also may be passed into each renal artery for additional images. The procedure lasts 30 to 90 minutes. The nurse asks the client about allergies to food, including iodine and any previous dye reactions. There is evidence that being allergic to seafood is not probable for an allergy to iodine or radiocontrast material, but the question regarding seafood allergy will most likely be asked as a precaution. Clients at highest risk for an allergic reaction to radiocontrast are those with previous reactions to dye, clients with asthma, history of heart, kidney, or thyroid disease, clients taking metformin or beta blockers, and older adults and or female clients. A laxative may be given prior to the procedure to empty the colon and ensure an unobstructed image. The nurse also reviews pertinent lab tests, blood urea nitrogen, BUN, and creatinine, CR, to assess renal function. Records vital signs and assesses peripheral pulses. The nurse instructs the client to void before the procedure. If ordered, he or she administers a sedative to promote relaxation before the procedure. After the procedure, the healthcare provider applies a pressure dressing to the femoral area, which remains in place for several hours. The nurse palpates the pulses in the legs and feet at least every 1 to 2 hours for signs of arterial occlusion. Monitoring the pressure dressing is important to note frank bleeding or hematoma formation. If either condition occurs, the nurse immediately notifies the physician. Another important assessment is for hypersensitivity responses to contrast material. Clients remain on bed rest for 4 to 8 hours. The nurse also monitors and documents intake and output. Client and Family Teaching 57.1 outlines education points. Urologic endoscopic procedures. Urologic endoscopic procedures use cystoscopy, which is the direct visual examination of the inside of the urethra and bladder using an instrument called a cystoscope. This procedure can also be used to examine ureteral orifices, the prostatic urethra in males, and ureters and pelvis of the kidneys. Small catheters are passed through the cystoscope to accomplish this. The cystoscope consists of a lighted tube with a telescopic lens. A video camera can be placed over the lens to get still or moving images. Cystoscopy or cystourethroskopy is used to identify the cause of painless hematuria, urinary incontinence, or urinary retention. It is useful in the evaluation of structural and functional changes in the bladder. The cystoscope is either inserted through the urethra into the bladder or is inserted percutaneously through a small abdominal incision. Urologists may obtain urine specimens, biopsy specimens for tissue examination, cell washings, cytologic analysis, or remove calculi, which are stones. Local anesthesia is used when the client is having a lower tract cystoscopy. For procedures that involve more of the urinary tract, spinal or general anesthesia may be used. Preoperative sedatives or antispasmodics may be ordered. Cystoscopy can aggravate any abnormality of the urinary tract. A urine culture should be obtained before testing. If a urinary infection was present before the cystoscopy, chills, fever, and possible septicemia may occur. The nurse observes the client for these and other symptoms and reports findings to the provider. Clients receive antibiotics after cystoscopy. The nurse records vital signs before and after the procedure. If general anesthesia is used, he or she should monitor vital signs every 15 to 30 minutes until the client is stable. Significant prostatic obstruction may result in pain and complete urinary retention after cystoscopy. The nurse administers medication for pain or bladder spasms post-procedure as ordered. Nursing Guidelines 57.1 has information related to the care of a client having a cystoscopy. Pyelography. An IVP is an intravenous pyelography. It's a radiologic study to evaluate the structure, function of the KUB. The KUB stands for the kidney, ureter, and bladder X-ray. This is performed to assess the abdominal area for causes of abdominal pain or to assess the organs and structures of the urinary and/or GI system. A KUB X-ray may be the first diagnostic procedure used to assess the urinary system. The retrograde pyelography is visualization of the complete ureter, and a renal pelvis is needed. This is performed during cystoscopy, causes or carries a risk of sepsis and severe UTI. This test is a procedure where the physician injects a radiocontrast agent into the ureter to visualize the ureter and kidney with fluoroscopy or radiography. The flow of contrast is opposite the usual outbound flow of urine, so that's why they call it the retrograde pyelogram. Nursing management includes NPO status for your patient, check for allergies, make sure they're not allergic to any dyes or the dye used for the contrast, check their vitals. You're going to need to have them do a bowel prep so that they can see these GU organs. They may experience burning, hot flushes, and metallic taste, nausea, and vomiting with the dye. You need to use, follow with extra fluids, no alcohol, and there will be dysuria after the procedure. So following statement, true or false? Performing an IVP carries the risk of sepsis or introducing microbes, which could cause a urinary tract infection. Biopsy, the purpose is to diagnose cancer and assess prostatic size or enlargement, also to monitor progression of renal disease and evaluates treatment of renal transplant rejection. There is a risk of postoperative bleeding. The nursing management, again, is to take vitals before and after, bed rest post-procedure, monitor for bleeding at the biopsy site, and also blood in the urine, prophylactic antibiotics, and watch closely for any signs of infection. Again, this is invasive. Diagnostic tests include the cystoscopy, which evaluates bladder structure abnormalities while filling, avoiding urethrography, which is a rapid series of x-rays while voiding. It is not done if a person has a UTI. Urodynamic studies evaluate the bladder, the renal function. They assess the cause of reduced urinary flow, so they're looking for blockage, urinary retention or incontinence. Uroflowmetry is also a test to measure post-void residual, and cystometrography, which is measuring bladder tone and capacity. Laboratory tests include the urinalysis, which is study of the urine components and the characteristics of it. It monitors the efficacy of treatment of known urinary and renal conditions. The urine culture and sensitivity to test for infections. A 24-hour urine collection and urine protein to see how the kidneys are filtering. Urine-specific gravity, urine osmolality, again checking fluids for possible dehydration or possible like diabetes insipidus if they were testing for that indirectly. BUN and creatinine clearance are a measure of renal function, so you're going to be watching those blood tests. And nursing management, post-procedural tests for pain and infection. And this is the end.